Добър ден, уважаеми колеги! Радвам се, че сте тук сред нас и че ще имаме възможност да направим на живо и в хибридна форма, разбира се, и колегите онлайн, 10-та юбилейна сесия Варна Ехо. Първо само да кажа, че ще настъпи една кратка промяна в програмата. Поради ангажираност на лекторите, чуждестранните лектори, ще започнем с лекциите. Откриването ще оставим в края на първата сесия. Имам удоволствието да модерирам тази сесия заедно с доцент Красимира Христова. Познавате всички, заедно работим от дълги години и заедно с Асоциацията по образна диагностика на сърдечно-съдовата система организираме и това събитие. Първият наш лектор ще бъде професор Йенс Уве Фогт от Лъвен, Белгия, който познавате добре, тъй като той е бил наш гост тук във Варна по време на предишни изяви в Варна Ехо, и разбира се и други ехографски курсове. Познавате го вероятно и в неговото битие на лектор в европейските форуми. Професор Фолк ще говори за един нов метод за оценка на диастолната функция, high frame ехокардиографии, по този начин за оценка на лузитропните свойства. Jens Uwe, do you hear us? Hello? I hope that you see us. We can't hear you. I'm very glad that you have managed to join us and on this 10th conference Varna Echo. You have been several times our guest, and we are happy to have you again. I presented you to the audience, and I think that you make an interesting presentation of this new method of evaluation of diastolic function. So you may start your presentation.
Thank you very, very much for the invitation, Professor Jotov, Kashimira. I'm very happy that I'm invited to your anniversary meeting in Varna. Unfortunately, I cannot be in person there because there were travel restrictions the last 2 years, and now suddenly we have too much to travel, and I'm at another conference. So the background with KU Leuven is fake. Actually, I'm somewhere else in the world, but it doesn't matter. So thank you for the invitation. Thank you for giving me this topic to talk about, and I would like to start immediately. Can you see my screen now? Is the screen okay?
Yes.
Okay, good. So then the topic is myocardial stiffness assessment by ultrasound. And this is actually a little bit like a look into the future. It's a look into a crystal ball, what echocardiography might offer us in the future. And for these stiffness assessments, we need high frame rate echocardiography, and that's why I would like to start with that, my talk. You know how normal echocardiography works. So normally you send out echo pulses, and these pulses are reflected somewhere in the depth of the body, and they return to the transducer. That takes a certain amount of time depending on the velocity of sound, and for a normal round trip of around 30 centimeters, we are at around 200 microseconds for one impulse returning. So that means we can do around 5,000 impulses per second. That's physics, that's all what we have. That means, on the other hand, if we want to build up a sector image of around 180 lines per sector, as we normally do, and we have 5,000 lines per second, then we can come up with a frame rate of approximately 28 frames per second. More is not possible. So how can we improve that? Because we cannot go beyond the laws of physics, but we can maybe tweak it a little bit and apply some tricks. So what we usually do is we apply one impulse for one line, but you could theoretically think of having a broader impulse. And so it's not a single line, but it covers like 2 lines. And then you focus your ultrasound beam only on the receive side. So that means you're listening in a very certain direction in one line and the direction of the other line. And in that way, that means multi-line acquisition, 1 impulse, 2 lines acquired. In that way, you can double your frame rate from 28 to, let's say, 56 frames per second. This is what is done nowadays in the ultrasound machines, and 56 frames per second, this is what you usually have on your ultrasound machines. But in theory, you could push that idea further, and you do not focus anymore at all when sending out the ultrasound impulse. You're just sending it in all directions. And with that, you cover the entire sector area with 1 impulse, and then you focus your lines only when you receive. So you listen in different directions only and build in this way an image. And when you do it like that, then 1 impulse is enough to acquire an entire 2D image. And then you can use 5,000 pulses per second and you get 5,000 frames per second. Of course, that's not so straightforward as it sounds. It needs quite some machinery. And this is our experimental ultrasound scanner that has been built by our engineers in the Medical Imaging Research Lab in Leuven. And this is a fully programmable machine, and it acquires all the echoes from the acquisition in a memory at once. And then afterwards, you calculate these scan lines, and that's tons of data. It's actually 1.5 DVD per acquisition of data that have to be processed. And at the moment, that takes around 4 hours when you calculate it on a normal computer. And when you have some special programs, you can get down to 15 minutes, but it's still quite a bit of programming, of calculation work for the computer. And also the image quality is not perfect, because you have to imagine that the energy that you usually use for 1 line of your image, this energy is now used for the entire image. So it's 180, 200 times weaker what you usually have. And that's why you have a rather bad signal to noise ratio. And I show you here typical images that we get. So this is 5,200 frames per second. This is then compounding images. That means we average 2 or 3 or 6 images together to improve the signal to noise ratio. And that, of course, costs us a bit of frame rate, but still we are at around 2000. And here you have an image with around 1000 images per second with 6 diverging waves compounded. And this is what we usually use for our studies and experiments. The question is now, why do we need such high frame rates? Well, sometimes things happen very quickly and we do not really understand what is going on. And therefore, it's good to have high frame rate, because if you can temporarily resolve what is going on, then you learn much more about the processes that happen inside the heart. And one of these things is shear wave imaging, what we can do. So what is a shear wave? A shear wave is a wave that basically travels in a certain direction, and the oscillation of the tissue or the matter is perpendicular to the propagation direction. And this is what physicists call a shear wave. And we can have these shear waves also in the heart. For example, if you have a valve closure like the mitral valve or the aortic valve closing, that makes the myocardium shiver in a certain way, and this shivering propagates from the base of the heart towards the apex. And when we have high frame rate imaging, then we can measure this little tiny shivering. Why is that interesting? Because the propagation velocity of this shear wave, this is caused by the valve closures, this propagation velocity is directly related to a very interesting parameter, and this is myocardial stiffness. So the faster the shear wave travels through the myocardium, the stiffer is the myocardium. And this is a physical relation, so there is no assumption or anything around it. If you have the shear wave velocity, you have the stiffness. And this is how that looks like. This is one of our high frame rate images, and you see now the motion of the myocardium the acceleration of the myocardium color coded. This is interesting, but not so instructive. So I give you an M mode across this parasternal long axis, across this septum. And now you see clearly what's going on here. We clearly see that there is obviously a wave that travels from the base of the septum towards the apex of the heart. And the steepness of this blue and yellow line tells us something about the propagation velocity of this wave. So what we are doing, we do these M-modes and then we measure the steepness of these lines. And with this, we have the propagation velocity of the shear waves. So how can we do that now in the clinic? How can we use that? Let's think about, for example, diastolic function. Diastolic function is something that is determined by two things. One is relaxation that happens at the end of systole and at the early part of diastole. And the second parameter that influences diastolic function is compliance. And compliance is a mechanical property of the myocardium, and it's there all the time. And in the second part of the diastole, this compliance is the determining part. So if we could measure compliance with shear waves, then that would be a big step forward in analyzing diastolic function. And how can we do that? I remind you on your physiology lectures, we measure the stress-strain relation. So we measure how much force it needs to extend the tissue, to stretch the tissue. And this curve, the relation between the stress and the strain is this thing here. That is what we know as the end diastolic stress-strain relation. So at the latest point of diastole. And when we measure the steepness of the curve in a certain point, then we get the operating stiffness at that state of the myocardium. If the myocardium becomes stiffer due to a certain disease, then the curve changes its shape. Usually it becomes more steep. So when we measure now the steepness of the curve, we get a higher value and a higher stiffness of the myocardium. Of course, it's not a line, it's a curve. And therefore, it can also happen that the stiffness increases just by increasing preload. Because if we fill the ventricle, also then we expand the heart and then we move up on this curve in a more steeper part. So increased stiffness operating stiffness can mean that either the heart is more filled, or that the myocardium is stiffer. This is the stiffer myocardium and this is the more filled ventricle. Both of these things usually in disease go together, so that this distinction is maybe not so relevant for clinical routine, but just to point that out, that we have to distinguish these two conditions. And I would like to start with some experimental data which we obtained in pigs. We looked into 15 pigs and we did different experiments that changed the preload. There was a preload reduction, an afterload increase, a preload increase with some fluid. And in the end, we did an ischemia reperfusion injury to the septum so that the stiffness of the septum increased. And you see that the shear wave speed after these interventions followed very nicely what we would expect that should happen. So if we reduce the preload, then the shear wave speed goes down. If we increase the preload, it goes up. And when we cause an ischemic injury to the myocardium, it gets even stiffer. When we look at our clinical data that we have obtained so far, or that have been obtained so far, I would like to start with a paper from a fantastic group in Paris. This group has done pioneering work in this field of shear wave imaging, and they came up with a paper where they measured shear wave velocities or myocardial stiffness, which is sort of equivalent in these graphs. And they found that there is a dependence on age. This is something which we assumed all the time, but now we have really clear measurements that the stiffness of the myocardium goes up with age. But what was even more interesting, what they found, was when they looked at hypertrophic cardiomyopathy patients, then these patients had a much increased stiffness of the myocardium. And this was not just 5 or 10%, it was really double the stiffness or more than double the stiffness of a normal heart. And that means that we have a very strong signal in disease, which we can use clinically. This is data from Leuven, from our lab, where we have looked into normals, volunteers of different age groups as well. And also here we found very similar things. We looked at the shear waves occurring after mitral valve closure and after aortic valve closure. And you see in both cases we have an increase in stiffness in the myocardium just because of the age. What was more interesting was that we saw in patients with amyloidosis that these patients had a double stiffness of normal hearts even when they were age-matched. So we see also with our method, with our machine, a very strong signal that we have clearly abnormal values in myocardial pathology. And this is another comparison where we look at the shear wave velocities according to the diastolic dysfunction grade obtained by the regular echocardiographic guideline procedure. And you see also here that there is a nice correlation. And on the right side, you see the E over E prime, which is something that is supposed to reflect the filling pressure of the heart. Also, this correlated nicely with the shear wave velocity. We also have looked into something very common, which is hypertensive heart disease. So compared to healthy controls, we looked into hypertensive patients with concentric remodeling, which is the more mild form of hypertensive heart disease, where the myocardium gets thicker but doesn't really change structurally. And we looked into concentric hypertrophy, which is the more advanced stage of the disease, where you have changes in the microstructure of the myocardium, for example, connective tissue growth in between the myocytes. And what we found was that in these patients with hypertension, the shear wave velocities were increased now at mitral valve closure, so the end diastolic shear waves, but they were not significantly increased in the concentric remodeling group, so in the mild form of the disease, but they were significantly increased in the patients with concentric hypertrophy. We also looked into transplant patients. We studied 47 patients after around 10 months after transplant, and they got all their regular follow-up with the right heart catheterization. So we also had right heart catheter measurements, and they all had an MRI for characterizing the fibrosis inside the tissue, and this was done with a T1 mapping. And when we compare the wedge pressure measurements, which is the current gold standard to look at the function of the heart in transplant patients, to the MRI T1 estimate of myocardial fibrosis, then we see a rather good correlation. But when we look at our shear waves, then you see that this correlation is much better. So in other words, we have a non-invasive echocardiographic method that is better in determining the fibrotic stage of transplanted heart myocardium than the gold standard invasive measurement which is currently used. So that could be a really promising step forward in echocardiography. And I would like at the end show another study where we just looked at patients that went to the cath lab and got some pressure measurements in the left ventricle, 70 consecutive patients with a wide variety of pathologies, and we were interested in the filling pressures. And all these patients were scheduled for a heart catheterization, either left or right heart. So we had either the left ventricular end diastolic pressure available from the left heart measurements, or we had the pre-A pressure from the left ventricle, or we had the mean pulmonary capillary wedge pressure, which is about the mean atrial pressure. So we refer to the last two as the left ventricular mean diastolic pressure and the left ventricular end diastolic pressure. And when we compare these invasive pressure measurements to the standard echocardiographic parameters that are used in the clinic for diastolic function assessment, then none of these parameters correlated very well with the filling pressures. And the detection of left ventricular, of elevated left ventricular filling pressures was rather bad, according to the guideline recommended algorithm. And here I show you the correlation of the left ventricular and diastolic pressure. With the shear waves, we found again a rather good correlation. And when we put a cutoff value of 5.27 meters per second for the shear wave velocities, we had an excellent distinction between normal and elevated left ventricular and diastolic pressures, which was really surprising and impressive. Ladies and gentlemen, let me summarize as follows. High frame rate imaging with up to 5,000 frames per second is an emerging echo technique. We can use it to measure shear wave propagation velocities, and we can also use it to directly assess myocardial stiffness. In the clinic, operating myocardial stiffness reflects both changes in myocardial properties and elevated filling pressures, but these two things often go together, so that it's maybe not a big problem. And currently, the measurements are limited to the septum, what I showed you in the beginning. This is the region that we can access with our technique. We hope that we can expand that to other regions of the myocardium in the future, but this is something where our engineers are still working on. But I hope that technical developments will overcome this limitation. And it needs to be mentioned that this is, of course, a group work that you can only do when you have a research team which consists of engineers and medical people. So I would like to thank my colleague Jan de Hooge, who's leading the engineering team. And here you see all the fellows which are working on these studies. Thank you very much for your attention.
Thank you very much, Jens-Uwe, for the nice presentation and very interesting. I think that we have time for a couple of questions, if you don't mind.
No, not at all.
First of all, I would like to ask you, this is very interesting measurement of stiffness of the myocardium. And you mentioned that it may distinguish the healthy myocardium from non-healthy, let's say, myocardium. And we usually see this increased stiffness in patients with some kind of hypertrophy or fibrosis and so on. My question is, are there any data that shows that this method can distinguish between the different causes of hypertrophy? For example, can we distinguish between left ventricular hypertrophy due to hypertension, due to hypertrophic cardiomyopathy, or due to amyloidosis?
We are measuring stiffness, and we cannot do histology. And this is the standard, my standard answer when we are talking about what can we distinguish with echocardiography. We cannot look into the myocardium. This is not a microscope. We can only measure physical parameters. And if these physical parameters are similar in several pathologies, then we cannot distinguish them. So we can tell if there is increased stiffness. We cannot say why the stiffness is increased. That still needs clinical reasoning and further investigation with other techniques.
Okay, thank you.
Thank you, Professor Voigt, for the very interesting presentation. I think that the first part is very technical, but actually the very high frame rate, this is the one of the possibility to increase the temporal resolution of the images. We're starting a couple of years with the strain, now spoken about the shear strain. What do you think where we are going after 10 years in the echo?
You want me to say 10,000 images per second, but I don't think so that we will do that. This is at the moment really at the limit what physics allows. The theory of shear wave imaging or of high frame rate imaging was around for, I would say, almost 2 decades. I remember one of our Leuven meetings 20 years ago when Bart Bijnens was talking, and he was mentioning several thousand frames per second, and that would be theoretically possible. Yes, theoretically it was possible, but at that time we did neither have the computers nor the probes to do these things. Nowadays, technology has advanced, and we have probes where we can address each crystal in the probe separately. We have a beamformer which is in the probe built in, and we have computers that can handle all this amount of data and that are fast enough to process this, and only therefore we can now come up with a solution that really makes it possible what has been predicted 20 years ago. So physicists predict some several thousand frames per second. I haven't heard anybody who predicted more so far. So I think with regard to frame rate, that's it.
Thank you.
You mentioned that, in my opinion, measuring the diastolic function is much difficult than systolic function. It's not so straightforward. Because if we look at measuring the diastolic function, we have mitral blood flow, we have TDI, we have left atrium volume and left atrium strain, myocardial strain. We have even looking at the right ventricle in order to consider the diastolic function. And in your opinion, where is the place of this new method in all these, let's say, bunch of methods for measuring diastolic function? You show that it surpasses in a way some of them and much more sensitive in measuring diastolic function. But in your opinion, how this new method will position in measuring diastolic function?
I think what we have shown so far, I would dare to say that we can tell something clinically relevant about late diastole. So at the moment we look at passively or at shear waves that are induced by mitral valve closure. That's end diastole, or maybe a little bit later than that. And these shear waves tell us something about end diastolic stiffness, and they are related to filling pressures and to myocardial property changes. It would be, of course, very nice if we could measure at other points in the cardiac cycle. That would give us the option to say something, let's say, about relaxation, if we could measure in the early diastole. That would even give us the possibility to say something about contractility, if we could do that in systole. However, for the moment, we are limited to these passively induced waves due to the valve closures, because you could think of inducing a wave also by a mechanical event, so by pushing the myocardium, tapping on the myocardium, but for that you have to open the thorax, so that's not good. But what you could think of is having a strong ultrasound impulse that moves the myocardium a little bit, and then it starts to shiver and does the same thing. And that could be induced at any time of the cardiac cycle. In theory, that works. Practically, that works in experiments. But we are still working on implementing that in an ultrasound machine in a way that this can be really used in patients, in humans, in a safe way and in a reliable way. But then we basically can measure diastole directly, and then we don't have to calculate anything anymore from strange algorithms and decision trees.
Okay, thank you. Колеги, имате ли въпроси още към нашият лектор? Ако няма, thank you very much, Jens Uwe, and I hope next time you will see you in person here in Varna. Thank you very much for joining us. And stay healthy and good luck. Thank you.
Thank you. Bye.
Bye.
Ние продължаваме към следващия лектор. It's my pleasure to introduce Professor Alan Fraser. I think there is no time for the introducing. Professor Fraser is very well known in Bulgaria. Welcome in our meeting, Professor Fraser.
Thank you, Krasimira, and thank you, Jota, for the invitation. Can you confirm that you can hear me?
Yes, thank you.
Excellent. We have that working now.
Yeah.
And I'm sorry also not to be there in person, but I'm grateful for this invitation, and I hope the meeting's very successful. Let me, I'm all ready to share, and it's just, I'm using a different computer today, and I've got a privacy setting coming up. That's not great. I should have tested this computer. I'm using a different laptop, and it's, I have to, okay, sorry. Can you see this, what I'm doing? You can't see anything yet.
We see you, which is a pleasure,
yeah.
Of course.
I do apologize. I'm wondering if I should just swap computers. I have to set the security settings on this computer, so I apologize. Just give me one moment. You can see that I'm not a digital native. Oh dear. If you could give me 2 minutes, I'll swap to the other computer because it'll be faster. I'm sorry about that.
Would you, Alan, do you have time in order to...
You have the slides there. Do you want to show them for me? Can you do that?
Имаш ли, да, имате ли слайдовете му? Може ли да ги пуснете вместо него? We'll try to. No? Just a second, please. Okay, now I think. Can you see them?
I can see that.
Yeah,
Can you see
okay.
that?
Okay, we see them, yes.
So
You may go.
we'll use you presenting the slides, and I apologize for that.
Okay.
And thank you again for the invitation. Next slide, please. While I was preparing for this meeting, I happened across this program from 2001. I didn't realize that I'd kept it, but here it is. And I must say, at that time, I never imagined I'd still be joining you 20 years later. But what's more interesting even is that I'm still talking about left ventricular systolic function. You can see that my presentation then was, what do we need to know from echocardiography? And actually, we're still thinking about that. And I'll review in this presentation why it is that we're still not able to get agreement from clinical colleagues to be more smart in the way that we measure left ventricular systolic function. Next, please. But firstly, congratulations to everyone for your 10th meeting. They've been very successful and I must say very enjoyable, and thank you for involving me. Next. So we will start with a brief case. Here is a 45-year-old man with severe breathlessness, with a heart that you can see is behaving very poorly. How would we describe this? Is ejection fraction going to tell us what we can't even see clearly on this image, which is that there's severe early diastolic dysfunction and regional systolic dysfunction, as well as apical rocking when the image on the right was moving? Next. So look at the M mode, and you can see where the arrows are, very, very slow early diastolic relaxation. And with strain imaging on the right in the septum, you can see that the middle of the septum is actually expanding rather than contracting, something that we hadn't seen, just eyeballing global systolic function. And the point is obvious, but still people look at the ejection fraction as a summary of left ventricular function that they think is going to be helpful, whereas in essence it tells us very little. This patient had very severe lymphadenopathy and also cardiac sarcoidosis with regional disease and very poor relaxation. Next, please. So let's go back to the beginning. Probably this was one of the key papers in talking about the fraction of ejection or the fraction of emptying of the left ventricle, in fact, with Eugene Braunwald, now 50 years ago or more, 60 years ago almost. And you can see that with a nuclear technique, they were looking for some first method of measuring and putting a number on left ventricular function. And they came up with the suggestion of the stroke volume ratio to the end diastolic volume. But of course, it's a ratio, and if you only use the ratio, it can be misleading because you can have a very large ventricle with a preserved stroke volume and a very small ventricle with a high ejection fraction with a low stroke volume in different circumstances. So on its own, ejection fraction, unfortunately, is not extremely informative. And as you can see, they did think that it would provide fundamental information on the hemodynamic analysis of left ventricular function. But I think that has not stood the test of time. Next. Here is what you would expect with a normal distribution of a continuous variable, a normal Gaussian curve and a cumulative frequency curve that you see there, which was what these authors found more than 20 years ago when they analyzed an echo database of more than 6,000 subjects. But next, if you look at the, next please, if you look at the left ventricular ejection fraction measurements in their database, and please click again, there was a, next please, there was a bias at 50%, just where you would want to make a clinical decision about the criteria for heart failure, for example. Below 50%, the investigators had underestimated the ejection fraction, and above they had overestimated. In other words, there was a bias to avoid the cut point in the middle. And that was because ejection fraction had been estimated and not measured. So this just shows the importance, if we do use ejection fraction, of measuring it. Next, please. When we do measure it, however, we know that there are differences between different methods of imaging the heart. And I've just circled on the right where two different ejection fractions disagreed whether the result was below or above 35%. And in 1/4 of these patients in moderately large series, there was significant disagreement. So if we're using cut points, single cut points to make clinical decisions, for example, you might speculate you put in an ICD below 35%, we're going to have considerable variability and some inappropriate clinical decisions. Next, please. Also, within a method, now this is not multiple imaging modalities, but just echocardiography, we still have, even with new methods, a coefficient of variation for left ventricular ejection fraction of 5 to 10% when you look at inter-observer variability. And it's worse when you reacquire new images, of course. That means that there is considerable difference between consecutive measurements that might just occur by chance. Again, arguing against relying on single numbers for major decisions. Next, please. However, we do now have, and this is new since 20 years ago, lots of large imaging databases which can guide us as to what is normal. And here is a summary from the ECHO-Normal collaboration that was published 6 years ago of 22,000 patients, or adults, I should say, from around the world, showing some differences, particularly with higher ejection fractions in Eastern Asian populations than in Europe. And the percentages in red are the 50th percentile mean values, if you like, for these different populations. And the numbers also tend to be slightly higher in women than in men, which is a consistent finding. So that's one example of a large database. Next, please. But that same study also looked at the variability between different centers contributing their results to the meta-analysis. And this was an estimate of the 5th percentile, perhaps the lower limit of normal, amongst all these different studies. And you can see variation here of 5 to 10% in absolute terms for ejection fraction. Next, please. However, the next study that I'm showing you of fewer patients, about 2,000 patients, from a collaboration called the World Alliance Societies of Echocardiography Normal Values Study that you may have seen. That now compares along the x-axis multiple countries around the world, and they do not seem to show major differences between different countries, or underneath very large differences between different ethnic groups, either for men on the left or women on the right. But notice underneath where the mean values fall, they're between 60 and 65%. Next, please. And this is a study now more recent from the European NORA group, but this is with 3D echo, and so their normal reference population is only about 450 subjects, both men and women. But if you look in the green bars, you will see that in women on the right compared with men on the left, again, there is usually a small increase, a higher mean ejection fraction, but with the values again within that range of 60% or just a little less. Next, please. And we now have similar values from cardiac magnetic resonance imaging. And I'll show you 2 or 3 studies from the UK Biobank, where, of course, we have a huge database. I'm not involved in the study, but there is a huge database of normal subjects who are going through detailed imaging protocols. And I believe they've now studied about 50,000 people. But here are their values for men and women, and you can see the mean ejection fractions of 61 and 58% higher in women, and then men 58%. And they've also usefully, as you can see in the center of the slide, reported their results as reference ranges rather than cut points, which I think is much more sensible. And also, of course, between one and the other, there's a borderline zone, as you see in yellow, where the imprecision of the measurement means you can't be sure where the patient lies and what the significance of their measurement is. Next, please. And interestingly, the same authors looked at the relationship between global volumes and function of both ventricles and atria, compared with some common risk factors. And if you look on the left, on the right-hand bar of the left-hand group, left ventricular ejection fraction, you see that it is coded green and orange, meaning that it's related to systolic and diastolic blood pressure. And in fact, ejection fraction is a load-dependent parameter, and that's why it's related to blood pressure. Whereas 2 columns to the left, end systolic volume, for example, which is probably more useful, is influenced by exercise and the fitness of the heart. So this is the first clue from the data that I'm showing you that stroke volume, or more probably end systolic volume, is probably much more useful than ejection fraction. And perhaps Brownwald and his colleagues chose the wrong measurement when they started to try to do this. Next, please. There's been another study from the UK Biobank, and this is in nearly 17,000 subjects, where they have looked at the relationship between global function and genome analysis, genome-wide analysis. And left ventricular ejection fraction correlates with 2 or 3 of the mutations that they identified, but not with many, compared with, for example, the mass to volume ratio on the top right, or again, end systolic volume. On the left above, you can see the correlations between the genotypes for the different variables, and on the bottom left, the correlations for phenotype relationships. So there you will see that left ventricular ejection fraction has a correlation with end diastolic volume of only minus 0.1 in this series. So on its own, it's not telling us very much about volume at all, in fact, nothing. It correlates best with end systolic volume, again suggesting that that might be a single parameter to use. Next, please. So we're left with, historically, huge variation, borderline zones differences in definitions of normal, but in this historical survey that was published last year, you can see most of the previous guidelines have reported normal ejection fraction at 50% or above, sometimes 55% or above. Now, how does that correlate with where we stand in Europe now with our most recent guidelines, and what is the consensus on how we should use this new information about the fact that ejection fractions in healthy populations are actually higher than they have been stated to be in the past? Next, we look first at the recent ESC heart failure guidelines that were just published. And unfortunately, they have referred back to tradition, and they have ignored all the data from these large databases, which I know was presented to them for consideration. But the summary report states that they have decided on the classification, and that's the key word. It was a choice, a vote of the committee to keep the cut points of 40 and 50%. To me, this is illogical. I've been involved in similar groups with similar processes in the past, but I think we can do better than that now. But they have also continued with this strange definition of a 10% range within the middle as a separate diagnosis, and they've renamed it as not mid-range, but mildly reduced systolic function. Next. Unfortunately, things get even worse with this so-called universal definition of heart failure, which you've probably also seen. And I've made this slide with it casting a dark shadow because I don't agree with what they've done. And indeed, it's been quite controversial. But these authors set themselves up to do this for the universe, which is fairly hubristic of them, I think. Next, please. What they have done is also propose, not summarize from evidence, but propose a new classification. And they've even introduced a fourth category of improved ejection fraction, which I think is utterly illogical because we know that patients will transition from one category to another just through chance if you use cut points and narrow ranges within a normal distribution. But they have taken heart failure with reduced ejection fraction as determined by an ejection fraction of less than 50%. And I know that American and European guidelines writers have spoken to each other to agree to use the same system. In other words, no one seems prepared to step out of line and report the evidence, which is now becoming very clear. Next, please. So how can we do this better? And here I think the National Echocardiographic Database from Australia is one of the most useful. Many of you may have seen this, but these are very, very large numbers of subjects, and this is for 250,000 men. The strength of this database is its size, and it's a multi-center collaboration, but the protocol acquisition for each scan was not determined in advance. And so there is variability, and once you start to look in more detail, you can question whether their conclusions need to be retested. But for something simple, straightforward, and commonly measured like ejection fraction, I think this is most useful. And now we're not trying to define what is normal on the basis of statistical considerations, but on the basis of the impact of the measurement on clinical outcomes. And to me, that's much more helpful, because here you will see that in men, and I've highlighted that with the red vertical line, below an ejection fraction of 60 to 65%, even minimally reduced between 55 and 59, each of these categories is significantly different. So mortality increases continuously below an ejection fraction of 60%, and this is data from more than 20,000 cardiovascular related deaths. Next, please. For women, it's virtually identical. Here, 237,000 women, and below the ejection fraction of 60, we can see a significant impact on subsequent mortality. So I think we now have very clear evidence, if we put all these studies together, that we should think of normal ejection fraction as 60% as a mean or above. But of course, it's continuously variable, and there would be logic in thinking about other parameters also. Next, please. And when we think about applying those data about mortality to clinical trials, here are two recent analyses on the left of Paragon and Emperor Preserved, so that's sacubitril valsartan and empagliflozin, and on the right, two trials of sacubitril valsartan. And if you look at the top left, you see that there was benefit below an ejection fraction of 60%. And on the right, if you compare both men and women, mortality was reduced, or the endpoint was reduced, hospitalizations on mortality, once you go below a mean of about 65 for women and about 60 for men. So the data from mortality now correlates with the continuous effect of benefit appearing below about 60%. And that's what we should be applying in clinical practice. Next, please. So to summarize, I think we should also, however, be looking at doing things differently. And this is just one slide showing in the meta-analysis of nearly 6,000 adults on the right that global longitudinal strain is a much more powerful predictor of outcomes than is ejection fraction. And on the left, it's also by far the best correlate in that study with interstitial myocardial fibrosis. Next, please. And this is the only example I'm going to show, but here are data from the Swedish Heart Failure Registry using artificial intelligence. And you can see on the bottom left that categories of patients divided by ejection fraction had very little impact or differential impact on value on outcomes, and that's survival up to 1 year afterwards. Whereas trying to analyze patients by phenotypes found by machine learning was able to discriminate much better between high risk and low risk groups. Next, please. So if I can summarize, again, thank you for inviting me. And what I've tried to do here is, if you like, a SWOT analysis, strengths, weaknesses, opportunities, and threats. And I see many more weaknesses and threats than strengths and opportunities for ejection fraction. But we can indeed still use it as long as we measure it. And I think we should interpret it together with the components. It's a ratio, and on its own, it's not nearly as useful, for example, as considering end systolic volume with the global ejection fraction. In future, it will be provided to us, I'm sure, because many manufacturers, probably most manufacturers, are now developing methods for automatically segmenting images and measuring them using machine learning tools. So we will get numbers from our machines, but what we will be able to do is to interpret those more smartly, considering their reproducibility and variability, and considering normal values by age and gender. We should remember that it is a continuously distributed variable, so any single cut point is arbitrary, and we need instead, I think, to look to values that have prognostic or diagnostic implications for the choice of treatment. And my final plea would be to people doing trials or writing guidelines. It's no longer acceptable to ignore all of this evidence. They need to be more open-minded, and we need to do our trials in a different way. Blagodaria. And thank you for showing the slides.
Thank you, Professor Fraser, for the very interesting presentation. Колеги, можете да зададете вашите въпроси към професор Фрейзер. I have one question, Professor Fraser. Sometimes when we look at together the longitudinal strain and ejection fraction, we could find some situation that the longitudinal strain could be decreased and with normal ejection fraction. How is possible to analyze this situation in this patient especially?
Yes, I'm sure I agree with you that longitudinal deformation is more sensitive to early changes in disease. But what we're not considering there is the issue that the shape of the ventricle can change, and indeed it does change as we get older. The ventricle becomes slightly more spherical, and we tend to see increased radial or circumferential deformation in early stage disease. My personal belief now, and I can't prove this yet, is that when you have an early disease of the heart, perhaps with increased stiffness, during diastolic filling, the ventricle cannot expand in the long axis direction as much as normal, so it expands more in a radial direction. And there are data from Peter Hunter, who's a modeler of the heart in Auckland, that I saw years ago, where he explained that the collagen skeleton of the heart isn't equally deformable in all different directions. So there may be asymmetric expansion of the muscle during filling in early disease. And if that was the case, then if you expand less in the long axis, you will have less systolic function by the Frank-Starling relationship. And if you expand more in a radial direction, you will increase the end diastolic length of the myocytes more, and you will get more contraction. So it's possibly reflecting subtle changes in shape, but certainly we know that global function is maintained by compensatory responses, while early systolic function is reduced. And of course, none of that is visible if you just look at ejection fraction. It's the argument for including global longitudinal strain or some other method for measuring long axis systolic function with any routine echo scan.
Okay, thank you.
Alan, thank you for the nice presentation. I must say to the audience, especially the young people, that this is the man who inspired Varna Echo 20 years ago. And he showed that, in fact, he's the one that has been present in all 10 issues of Varna Echo without any.
Did I not miss one?
Yeah. So thank you very much for what you have done and for your support through all these years, and always challenging presentations and very interesting ones. I also agree with you, and maybe most of us will agree that ejection fraction is not the perfect way to measure systolic function. Even it's not measured, as you said, it's calculated, estimated. But still, as you said, this is the measure of systolic function that is mostly used to discriminate patients with preserved ejection fraction, with mildly reduced ejection fraction, and reduced ejection fraction. And it still continues to be this, although we all have this criticism of ejection fraction. Why, in your opinion, these guideline writers stress and stick to the ejection fraction instead of trying to introduce something else? This is my first question. And the second question is regarding the situation with preserved ejection fraction. You mentioned that probably we should think of 60 rather than 50% as a cutoff point, if used at all as a cutoff point. Do you think that these, what you said is supported by the last data from clinical trials with ARNI and SGLT2 inhibitors showing that probably we should switch a little bit more than 50% and consider the effect of some of the treatments even in this, let's say, well, normal preserved ejection fraction?
Thank you, and thank you for your kind comments, Yotto. It's been a pleasure. I do think I missed one meeting on congenital heart disease when I said I wasn't expert enough. But we won't argue about that. So your first question about guidelines writers, and frankly, I don't understand. I was an expert reviewer for the most recent European Society of Cardiology guidelines, and I sent them pages and pages of evidence and got a reply that they'd voted. And I don't understand. I think part of the problem is that guidelines writers are clinical trialists and they're not imaging specialists. And imaging specialists think much more pathophysiologically and are much more critical of the measurements that we make. And somehow these two communities don't interact enough. But I also think that clinical trialists don't use the insights from pathophysiological studies as much as they could. There's also a lot of inertia, which is very strange. Because it's been the measurement that we've used all the time, as I showed you since the 1960s, then it was used in many trials and it does work to some extent. The fact that something else would work better is true, but doesn't seem to interest them. And I do not understand the argument that just because we've always used it and it worked, we should keep using it and nothing else. To me, that is illogical. It's against the spirit of science, where you continuously try and improve and reflect the evidence. And as I showed in my talk, there is data from thousands and thousands of patients now to provide that evidence. And to go to your second question, then of course, indeed, the evidence also supports exactly what you said, which is applying different cut points or different ranges when thinking now about treatment. Because treatment will not work in somebody with an ejection fraction of 51%, but be effective in somebody with an ejection fraction of 49%. That's just crazy. It's a graded response across the range, and we should be extending the range where we use these drugs. But I also think we should do trials that are not based on ejection fraction, but on other measurements. Do them across the whole range of ejection fraction, and then find out where they work.
Okay, thank you. Имате ли въпроси, колеги? Ако някой има въпрос към професор Фрейзър, моля към микрофоните. Ако няма, thank you very much once again and hope to see you tomorrow also. Thank you very much.
So.
Bye-bye.
Thank you and
Up to now.
success
Thank
with
you.
the meeting. Bye-bye.
Thank you.